Sorry. Ja. Ja, ja. Ja, auf jeden Fall. Also, gibst du mir noch die Zeichen? Ist da egal machen? Ja. Ja. Aber vielleicht so, wer Fragen hat, was das schon Also wir hätten da, ich glaube,
Welcome everybody to our first oral session on the Basel. My name is Harish. I'm currently for the last one. We have a language in to speak English, and I just happened to be in Europe at the time. We really interested. Okay. So we have three very interesting presentations. I sharing the session, and the titles are all very interesting. And so I would like to invite Professor Belma from the Leiden University Hospital to start looking at development of the regulation on e-learning.
Okay, good afternoon, everyone. Thank you very much for the opportunity to present our work on the development and evaluation of an e-learning curriculum on drug-related problems for community pharmacists. It's fine. Thank you. My name is Roma. I'm working in the population of pharmacy. University Hospital in Germany, and it's my pleasure to present this work on behalf of my colleagues and the first problem of the issue that the writing one, unfortunately, to the research. So, writing education focus in Dutch e-learning. In Germany, 1 in 5 patients is affected by drug-related problems, for example, drug injection or medication administration error. The community pharmacists are the last instance in the medication process to actually prevent such problems. Therefore, continuous training for English chances is necessary to focus on the we therefore aim to develop and develop multi-competency curriculum for English chances to detect and prevent reproductive problems in cooperation with the General Council of Baden-Württemberg. We conducted a literature research and data survey to identify reproductive problems that can be addressed in community farming. For every reproductive problem specified, we then developed an e-learning module. And finally, integrated these modules in an e-learning platform. A total of 10 calculated problems was made, for example, on the integration of the local problem to one problems. 10 calculated problems mean that we developed 10 e-learning modules, and they all share a common design with 4 main features and results to be used now. The end of these e-learning modules is the education video. These videos address well, we can store inside the calculated problem and also be able to complete steps on how to handle such a calculated problem in the past. Each module is rated a launch point, which means at the beginning and the end of each e-learning module, answers are identified in relationship. Furthermore, each module contains digitalization I need to deal the knowledge gained by the education video. Furthermore, there are provided education materials that can be education, for example, a patient user or a product educational item. At the end of each e-learning module, the pharmacists are asked to actually apply the content into and provide the implementation of activities. We then pre-test the first module development. And then in 2018, we pilot tested the curriculum with pharmacy for community pharmacy. After each module, which is the pharmacy, then completed, and therefore we receive an email providing the additional survey. For this pilot test, a total of 200 community pharmacies to develop. However, one person actually never knowledge. More than half of the community pharmacies successfully completed all the modules. About 80% of them stated that the departments were helpful to identify the patients affected by the calculated problems. Nearly 90% of them had more problems with patient counseling. Nearly all of them would recommend participation in their colleagues or will further alignment of counseling in patient counseling. So currently, analysts are conducted to determine how many calculated problems were actually identified and resolved by the community council. Furthermore, the feedback overall is very positive, so the curriculum of established and pre-training level managed more answers. So thank you very much.
Thank you, Victoria. And for asking questions, I would like to encourage everybody to maybe mention the name where you're from, because we don't know each other yet. So, any questions for you? Yeah.
My name is Christiane, I'm focused Berlin. Thank you very much, it was really interesting. And the feedback overall is very, very positive, but it's quite striking that you have only a very small proportion who's actually participating. So, if I understood it correctly. So what would be very interesting for me is when the others did not participate. Of course, you could evaluate, but could you think of maybe actively contacting them? Because it seems to be a good program, but not everybody assesses it. Do you know what I mean?
Yes. Thank you for your question. We don't actually know why some participants never had knowledge, but we do have some, but we know why some of them dropped out after the modules. The main reason was that they changed their everything, that they found that they I think that was the main reason they asked for dropping out of the I think it might be that it's kind of camera consuming or it's not good.
Questions? I wonder what was the age group of your classes in the debate actually, because that may answer some of the questions. But, you know, when the crop or range of the answers or the kind of answers.
We haven't really evaluated what the age was, I think it was how accommodations. But we know that most of them participated for but they were also some housing, but most of them were infants. But we don't know. Okay.
Why don't you commit? You did not recall, you did not assess the age in the anonymous.
Yeah, we did not ask for their registration process.
But you know who take part.
Yes.
So you could re-obtain the data. Check the code. Will you? Thank you for the
Also, I would like to address related problems in new models. Really look at there are most problems models can address themselves. We talked about some where they may have to protect the properties. In the long-term problem,
It was amazing. The year that cover primary problems in Canada and country and what there are all the time needs to contact the power. But I think we have to do the recommend on scale for 5 million pounds.
if you should, thank you for that. Thank you, João, from Ocean. And she was sure about the answers, you know.
This one? Yeah.
So thank you for thank you for my name is John Moore. I'm from the Department of Social Science and Technology. I'm going to present you a work that comes from one of my students, really part of the system. We tend to look into how transparencies council and follow-up, especially the tools oral instruments, especially the sorts of ones of hyperview and by sending conference. These are usually people that are in a situation of frailty, and thus they most of the times presented some malnutrition. And we wanted to see what is the experience of these pharmacies when going out of these products, because in Portugal, we're now in a situation where there is the possibility of working together with the individuals. So we bring the definition of an area that the individuals surround process working together with an ally that can appreciate the role of the current, especially when we're talking about nutrition. So we wanted to characterize how these products follow in council, because the perception that we got is that there is no real certain follow-up of infection. You need people just buy this and go. So we decided this study, historically study with the development approach. We started by designing an institute with the series of 20 questions that we done around 3 plus 5. And we applied it by a snowballs technique. So we identified substances and then asked them to identify more another substance that had to be working in pharmacy and had to have at least 3 years of pharmacy experience. So they have some things and I'm not novels in this connection. At the end, we obviously we were recording the HDs and institutions, and all after that we analyzed the institution. And the final study was completed by 19 pharmacists from 19 pharmacists. When we asked why the council or this what situation the council is our also and we got into the use of these supplements for diagnostic test preparation. For instance, for the primary colonoscopy, people have to repair with solid food, so we use these nutritional supplements to complement their intake of energy and protein. Also, they identified elderly patients and malnourished patients as reasons for counting supplements. Also, cancer and post-surgical patients and also diabetic patients. Those were the main reasons to come from these supplements in these products. Most of them report the cancer at least once every week. Economy is interesting because it's not very common to find this, but we have to report the cancer at least one supplement every week. The reason is for not supplying more with nutritional supplements or the barriers that we found for discount. The most preferred barrier was the price. Farmers refrain from consuming these supplements because they're affecting of the price that is practically too high. So even if they get in finance, they tend to not confidently because the price is too high, and so the price is too high, it will be eligible to be supplemented. Also, there are some formula not understanding or not knowing enough about to control this, and also some fear or not knowing enough from us to contribute to sexual operation experimental and qualification. We found that also for these barriers to be overcome, the most significant representation of the need for an information that could provide information could direct, the information regarding the supplement. Also, they could monitor the effects of these supplements So, pharmacists could measure the weight, could measure the body mass, and could plug into the treatment. And we will also count the pharmacy to check it or to do another kind of integration. Also, the reasons for the part of the soul about the importance of the color is to see what especially for Brooklyn, cotton and white and to the policy. I can just to finish it. So the technology that is now being great through multidisciplinary work with communications. We are now in the process of developing a platform where pharmacy nutritionists can interact and follow up with sessions, one of these sessions that will start the pilot of this new platform following the followers. So this is the first work from others that will follow. Thank you very much.
Thank you, Joel. That's sort of the reason for I think. So, are there any questions? So, what really struck me is we're talking to different advances, having a product in the pharmacy, they probably receive a benefit for patients, but at the same time, is there anything in your mind that is one year or
I think every time or they have this certain care that they tend to care for these patients. Also in this management because when they say that the price is too high, then remember these are mostly elderly patients. Elderly patients are so if you want to buy something like this, probably zeros bag for bottles are enough only for basic selling for only €8 or more. For many patients, it will be all of their patients. The percentage of the price. So I will buy the first one, but then they won't buy the next. So the department is better than the so I can have a bother and all of these persons that will not use the treatment plan because of the so they know that the person will need it, but they don't know how to communicate the need to go around the obvious and the price.
Just shortly, because you said it's a problem with pricing, of course, I completely understand. Isn't there some difference depending on the reason why people need this extra nutrition? For example, in Germany, for certain indications, for example, this cancer patient, there might be options to have a prescription for that. Is it not possible in Portugal?
Even if you have the nutrition, it will not be reimbursed.
Okay, so
It's not reimbursed, even with this nutrition. It could be a solution to this problem, but the scenario now is not, there is no reimbursement at all. So it will cost the same price anyway. No, probably there are some health insurance that will cover some part of the cost, but not the national health system.
So it's not really good like the nutrition recommends implementation and then it goes from there.
The period is dropping off, and some solutions can initially with collaboration with the manufacturers and try to put in place some kind of bundle scheme. So when people buy these products, even if it's 20 euros, it will follow up with more funds and nutrition. And a small reimbursement that could be paid for by the manufacturer, probably it will be easier. What we're trying to see just in this sort of pilot that we follow now is that these two professionals can work together using this platform to monitor and follow up. This is the first thing that we want to do.
Yeah, that sounds like a good idea. Having information, collaboration,
Yeah.
and really following patients. Thank you, Joao. Now the technical development. But I think I have not as well from the industry and here talks about explorative research on how to and how to pay the amount of we have to athletes.
Thank you for having me today. My name is Azrina. I'm a PhD student from School of Pharmacy, University of Nottingham in Malaysia. So today I'm going to talk about my research on health literacy and self-care empowerment among Malaysian type 2 diabetes patients. Okay. All right, so just a little bit of background about the prevalence of diabetes. So according to the International Diabetes Federation 2021 report, around 537 million adults living with diabetes globally. And in Malaysia, it is ranked the top 5 highest in prevalence in diabetes in Western Pacific region. And if you look on the graph, which a survey done by the Ministry of Health in Malaysia, you can see that the unknown diabetes and diagnosed diabetes increased from 2011 to 2019 in Malaysia. And also it's reported that 1 in 5 adults in Malaysia have diabetes, and that's about 3.9 million people aged 18 years and above. And in terms of health literacy, low health literacy among diabetes patients may result in poor self-care management and also diabetes outcome. And from the same survey, which is done by the MOH in Malaysia, it's reported that 1 in 3 adults in Malaysia have low health literacy. And the International Self-Care Foundation actually developed the 7 pillars of self-care, and the first pillar focused on knowledge and health literacy. So my research is a qualitative research where I explore the perception of pre-diabetes and newly diagnosed type 2 diabetes patients on their disease knowledge and management in order to empower self-care behaviors so that we can delay or prevent disease progression. So 22 participants were recruited through purposive sampling. 18 participant has type 2 diabetes, and then 4 has pre-diabetes. The participants were interviewed using semi-structured interview, using Microsoft Teams or telephone calls because it happened during the pandemic. NVivo software was used for data analysis, and all the data collected were coded and categorized into team using a thematic analysis. So from the data analysis, 4 major key themes were identified that empower patients to do self-care, which are accessibility to reliable resources, mental health, self-awareness, and also overcoming barriers to self-care. So the first theme, which is accessibility to reliable resources. So when I interviewed the participant, I found that when participants have access to reliable information, if they get to see the same healthcare professional when they go for their appointments, and also being signposted to this to the right healthcare professional, they are more empowered to practice self-care. So for example, here, the second one, seeing the same healthcare professional. So these participants say that if, let's say, I get to see the same doctor, I'll be more disciplined because the doctor understands me. So where they have the continuation of care, so they are more empowered to practice self-care. So team 2, which is mental health. Having just been diagnosed with diabetes, because my participants are newly diagnosed, could actually affect patient mental well-being, probably due because of diabetes distress or the stigma around diabetes. So continuous support from healthcare professional peers and also family is also important. So for example, if you look on the mental well-being, the participants say that from my experience, when I was diagnosed with diabetes, I felt really down and scared. So support is important for them to, manage their diabetes. Like one of the participants say that whatever they share on Facebook group, I feel like giving me the moral support. So he was explaining to me about why he joined a diabetes Facebook group. Team 3 is self-awareness. Patients who have good understanding about their diabetes may develop a sense of self-awareness to practice self-care because of fear of developing complication, or maybe they are aware of their own risk factor. So for example, the first participant said that I want to motivate myself because I've seen people around me who had their leg amputated and some passed away because of diabetes. And the last one is overcoming barriers to self-care. Participant mentioned that some of the barriers that they face to practice self-care, for example, lack of support, difficulty finding information, and also self-care is hard. The thought that self-care is hard. So all this barrier needs to be, addressed so that patient or participant can practice self-care. So in conclusion, with sufficient access to health services and reliable information, patients are more empowered to practice self-care. We need to also manage people with low health literacy through diabetes self-management education, so that we can increase patient knowledge and also awareness. And also the role of pharmacists needs to be further enhanced because pharmacies are easily accessible to the public. So therefore we could be a key player in self-care education. Thank you.
Thank you. Any questions? Okay.
Thank you very much. What can you say about the numbers before 2011?
The numbers in 2011.
Yes, because it's a very steep rise today. So why is it not of nutrition?
The numbers are 2019 is 18.3%. So I think in 2011 about 11%, and 2015 is about 15%. Can't really remember the numbers, but it increased. So it's probably because in Malaysia, the main risk factor is a modifiable behavior risk factor, which is unhealthy diet. So that's where there's an increase in the prevalence in Malaysia.
Is there any education going on in Malaysia with this?
We do have, like for patient who has been diagnosed with diabetes, the public hospital or the public clinic actually offers this diabetes medication therapy adherence clinic, but it's more for patient who's already been diagnosed with diabetes. So yeah, that's what we I'm looking for as well, like why they are not offered to newly diagnosed and also like pre-diabetes. So
what access do you have to information? Let's say they've been diagnosed, do they rely on professionals or their official websites?
they are like the Ministry of Health website. But some of the participants that I have interviewed, most of my participant are 45 years and below. I do have some which between 50 to 60 years old. So one of the difficulty they've encountered is difficulty to find information where they don't know how to use like Facebook or Google to get information. So the only information they get is from the healthcare professional they see every time they have their appointments. And yeah, there's a limitation on that as well. So yeah, yes. I mean, we do have like the Ministry of Health website where they tell you about, you know, healthy eating and all that too, because some of the participants don't know how to use the internet. So it's quite difficult for them to access this website.
So if I'm right, you explore health literacy. My question is, how did you control for health literacy in your 22 patients? Did you please how good or how bad were those?
Yeah. Well, in terms of health literacy, obviously you need to use like a survey or questionnaire to assess the patient health literacy. I do actually give, I have this health literacy questionnaire, which was developed by University of Swinburne in Australia. So I use that to assess, I give the survey to the participant to fill in. But that's another part of the project that I will look into. But from what I've gathered from the survey, most of the participants have low health literacy level.
So your 22 participants have low health literacy?
Yes.
So is it low, but in average? My question is, are there representative for Malaysian population or not?
From the survey that was done by the Ministry of Health, they reported that it's low health literacy, but they look into the general, because they adapted the health literacy survey from the European. So they adapted that one. So it's reported that 1 in 3, like most of Malaysians have low health literacy. So with my research, because it's a very small number, 22 patients, so it's that I cannot say that it's, you know, it represent the whole Malaysian, but for my research, I think more than half of them are have low health literacy.
So my question is, are those 22 representative? Meaning, can you generalize your data, your results?
I wouldn't generalize my data, no, because of the small numbers, only 22 patients, yeah.
So what are you doing with your results?
Because my research is more on qualitative research, so it's basically just to see the behaviors instead of, the behavior, what actually encourage people or empower patients to practice self-care. So because I relate it with health literacy as well, in terms of access to information, access to the services that we offer. So so that's why I came up with the 4 themes through when I do the data analysis. Thank you.
Any other questions? No, I don't have one. Yeah, I think in general, the quality of research you have, it's not there for general, especially for, further research or getting an idea of what system they need in general. So I think we should thank all our presenters on our time and adjourn.
Thank you, Zara. Thank you, Sabina. Thank you. So thank you, all of you. Let me give some very, very few information about what you have on the table. So this came from Australia, direct to my office, and this is a present from the Sydney group, from the the team for you. So please take it with you or read it and find it tomorrow. Anyway, take this a small souvenir from our school. So the next program point is to have the local welcome event at the Pharmacy Museum. And you will be guided by the ladies with the blue shirt, t-shirt. So the idea is to go at the group and move slowly. It's about 10-minute walks, but when 20 people walk like, so it might take 20 minutes. And then we will have some drinks and a little bit of alcohol. Those of you who are allowed to drink alcohol, and it's up to 8 p.m. So I will now start to take my ICT, but please take your time and yes, you can follow the